Cuando quiera, Jordi.
Hola. Bueno,
Hello.
otra vez estamos aquí de
Good
nuevo.
morning. Good afternoon again. This is the second session for this webinar. Yesterday's session was a great success, and I would like to show my gratitude for that. And today we are starting the second session of this International Fabry Virtual Congress, and we will talk about quality of life and well-being. These are very relevant topics in Fabry. First of all, we will talk about the impact of the COVID-19 pandemic in the situation that we have experienced and how patient care and attention was in that situation. Juan Politei will tell us more about that from Buenos Aires. And then we will also talk about nutrition and diet. This is always very important. Our society has always been very keen on finding other alternatives. And Dr. Cristina Montserrat from Barcelona will tell us more about that. And then we will have a Q&A. You have the possibility of asking your questions and we will happily try to respond them all. We will also talk with Eduardo Brignani, our psychologist. He will talk about Fabry. He will tell us how to stand up to Fabry in a certain way. And then we will talk with Natalia Rubio. She will tell us about how to awaken our senses and sexuality, which is such an interesting topic in these kind of situations. And without further ado, let me say again that I would like to express my gratitude to all the speakers and to all the attendees who are here in this, frankly, a very interesting meeting. We have attendees from around the world, and we also would like to thank Fabry International Network. We are part of it, and we would also like to express our gratitude to the pharma industry for their help in organizing this event, and Dr. Pinto, Guillem Pinto, who's always been there backing us up to organize such a relevant agenda. I will give the floor in a second to the first speaker today, Dr. Juan Politei. You have the floor, sir. Sorry, Dr. Juan Politei, let me introduce him first. He comes from Buenos Aires, Argentina.
Sí. Como decía, viene desde Buenos Aires.
He comes from Buenos Aires and he's a specialist in neurology. He works as a neurologist at the Foundation for the Studies of Neurometabolic Diseases, and he works at the Neurochemistry Laboratory with Dr. Nestor Chamoles in Buenos Aires, Argentina. He has worked extensively in neurology and he has a wide-ranging experience in neurometabolic diseases. And since 2002, he's been closely involved in Fabry disease research and in leukodystrophia and mucopolysaccharidosis. And he has published extensively in medical journals, and he is a very suitable person to offer us this talk. So I would like to give you the floor, Dr. Politei. Welcome.
Thank you, Jordi. Thank you, everyone, for having invited me. Can you see my presentation? Would you please confirm that you're seeing my presentation? I'm going to go backwards. As Jordi was saying, I am an adult neurologist. In the next 20 minutes, I'm going to talk about what has happened to us personally and what literature do we have concerning COVID and Fabry disease. I'm not going to talk about the pandemic per se. We're not going to talk about the symptoms of COVID-19 because we all know them. I just want to focus on a specific concept, Fabry disease. But when we found out that COVID was here, we wondered what's going to happen with our patients. Are we going to see the same thing in all patients, or is it going to be worse in the classic disease and not as aggressive in the late onset disease? What's going to happen with enzyme replacement therapy? What's going to happen with renal involvement? What's going to happen with vaccination? This is all the questions that we have already answered. But the most important thing concerning Fabry is that there's two types. There's not just one Fabry disease, there's two diseases. One is the classic disease. As you know, it is not as common as the late onset disease, which affects mainly the heart, or there's also a renal variant. And we see an accumulation of alpha-sphingolipid, and the manifestations are different. So the relationship with genotype and phenotype, we can say today that it exists. And from the biochemical point of view, a Fabry classic patient will have very few residual activity of alpha-galactosidase A between 1 and 2%, and they're going to have symptoms during the first 10 years of life. And the GL3 or substrate deposit, it's not going to be confined on the endothelium only, but we're also going to have it in the cells, in specific cells or differentiated cells. So, symptoms of classic disease on the left-hand side of the slide: neuropathic pain, GI involvement, hypohidrosis, cornea verticillata. And then in the second, third decade, we see renal and cardiovascular involvement. That's clear. And we told ourselves, be careful, because the first papers about COVID said that patients with COVID, especially COVID, is a respiratory disease. And so we saw often renal failure, patients requiring dialysis in the ICU. Patient had thrombotic components that could affect the coronary arteries or cerebrovascular system. We also talked about myocarditis. And so we see that patients can have severe involvement of the heart, the kidney, or the cerebrovascular system. And so we started to wonder, so if Fabry is not only heart, kidney, and brain, we see respiratory involvement. And so we looked at the literature because we saw a bilateral pneumonia that could progress. But what happened in the lungs of the Fabry patients? Well, we have papers saying that Fabry affects the respiratory system. And how? Usually the patients are not going to die due to Fabry respiratory distress, but we know that we see a chronic bronchitis, because chronic bronchitis, as you know, has a bronchial muscle cell hypertrophy. There's an immune hyperreactive reaction. And in Fabry disease, the GL3 deposit, depending on the hypertrophy of the bronchi and the epithelium, may lead to different consequences. We know that from autopsies, biopsies, and expectoration studies. Here we see GL3 ciliated cells. We see that also in CT scans. But we also know that due to functional respiratory studies, because for instance, spirometry has an respiratory obstructive pattern, and we see that clearly. And so we wondered, how can we compare COVID damage and Fabry damage? We had the possibility, together with colleagues from different countries, to draw these international guidelines for the management of Fabry patients. First, we said everything affecting COVID may be affected by Fabry disease. And looking for something practical, we said we're going to stratify the risk for a Fabry patient of behaving as a severe patient, that is, as a Fabry risk patient. And so, in the paper that we published, we try to stratify the risk based on the level of severity in an organ or depending on age and gender, knowing that Fabry is an X-linked disease. And let's have an example. I mean, I have a patient, and what kind of patient would have low risk? Here in green, we see that patients with late onset disease have less involvement because even though they have higher involvement of the liver and the heart, there's no other organs affected. If we move to moderate, yellow, here the patient may have renal damage, even though they are not on dialysis, they may have a heart disease. And this means be careful. But a patient with a transplantation, a renal transplantation, or with a severe heart disease, that would be a very high-risk patient. Concerning age and gender, well, if the patient is male and older, they're going to have higher risk. If it's a female patient with an X-linked disease and young, the risk will be lower. And so this is how you can classify the patients in this hypothetical risk stratification. Another question is that we know about COVID, we know organs that are affected, we know what Fabry patients have higher risk, and then we started asking questions about vaccines. And we follow different patients, and we saw that from the end of last year, beginning of this year, it was said that rare diseases in general didn't have a contraindication concerning vaccines. We followed a group, which probably some of you may have followed also, and we saw first that we had to vaccinate patients against COVID if they have innate metabolism errors. Second, these patients should be considered as patients at risk. We have to vaccinate them earlier. And third, use any vaccine you have in your country. There's no vaccine better than other, because we started to read European papers, and they were saying that the vaccine is not dangerous for Fabry patients. I could tell my patient to get a vaccine, but I wanted to have expert recommendations. And all this concerning immunization, it was to reduce the risk of COVID complications, but the patient kept on being treated. Okay, I'm going to forget about COVID. I have to treat my Fabry disease. And then we started to see papers such as this Italian one, very interesting, with 102 patients with lysosomal diseases. There were 15 cases of Fabry, and it's interesting to see how this patient did. We saw that 50% of patients had to stop the treatment for a while. These were the patients who were receiving therapy in infusion centers, in hospitals. Why? Why was treatment discontinued? Because the patient didn't want to go to the hospital. They were afraid of going to hospitals. Who would like to go to hospitals? And if they wanted to get an infusion, the infusion center was closed because the staff had COVID-19, etc. And then how could we manage this? We started to see papers published. Most of the papers were saying the following, that we had to keep on treating the patients. Patients who were receiving chaperones, oral pills, no problem, they can take the pills at home. But patients needed their infusions, if possible, at home. Look at the titles of the papers. How can I keep on treating patients despite COVID? This is what we wanted. We also saw scientific publications such as the Spanish Gaceta Médica. It was said that we have to promote home therapy in patients with lysosomal storage disorders, patients who may not have allergic reactions, for instance. And what did we do? This is ourselves in Argentina. We started to give infusions at home. Fortunately, in Buenos Aires, 80% of our Fabry patients were already at home before the pandemic. 80%, no changes. But what could we do for the people giving the infusions not to infect the people at home? We followed the measures that were used for patients in dialysis. We gave PPI for the healthcare providers. Here you see a patient with MP26 who's getting an infusion at home. And so why did we want to start giving infusions to patients again? Because it's been shown that we see a fast accumulation of the substrate when you discontinue treatment. I'm not going to read this paper to you. This was published 10 years ago by our group. It was a Fabry patient with good therapy. He discontinued therapy, and in 2 years, he went back to the situation he had 10 years earlier. And so why do patients worsen fast when they stop therapy? So we know today, this has been shown in animal models, that in all lysosomal diseases, but maybe more in MPSs, the C cells increase in size due to the intralysosomal deposit of a substrate, lipopolysaccharide, mucopolysaccharide. The lysosome is full of that substance. Initially, there is a feedback mechanism, which is not enough. It's intracellular. And we see resignaling, saying the substrate to stop accumulating. I'm representing this in this full bin. When you start ERT, that mechanism stops because now I have the enzyme degrading or catabolizing that substrate. The problem is that when we discontinue therapy, there is a new reaccumulation of substrate, which is very fast, and that feedback does not start that fast. So this is why that happened. We have the bin full, but we still keep on accumulating waste, and this will lead to lysosomal rupture and digestion, self-digestion of the cell. So to end on time so that Cristina can give her presentation, what did we learn from the pandemic? Well, remember, there's already a present damage in target organs. Patients at risk. All patients should get the vaccine because they are considered patients at risk. So we should immunize patients with lysosomal storage disorders. Any vaccine is useful. It doesn't matter if it's Sputnik, Moderna, or Sinopharma. We still don't have thrombosis situations in lysosomal patients. We have to discontinue treatment? No, we should not, because we're going to see the fast damage in the organs. We're fortunate enough because in 95% of patients who have been infected with the COVID and who have Fabry, we've had good results. We only had one death of a Fabry patient. We have transplanted patients or patients in dialysis infected with COVID, but who had a good evolution. And the same happened in the Gaucher disease. Some people are saying that immunological changes in the macrocytic or monocytic macrophagic system could be a protective mechanism from COVID. I forget Gaucher and I go back to Fabry. I don't know if this is happening in Fabry disease, but if you discontinue therapy, we're going to have accumulation of the substrate. And if I restart therapy, it doesn't mean that I'm going to get the benefit that I got earlier. So, dear friends, thank you very much for your attention. And I'm going to finish here and listen to Cristina's presentation. Thank you, Jordi.
Muchísimas gracias, doctor Politei. Ha sido fantástica la ponencia, la verdad.
Thank you very much, Dr. Politei. I really liked your presentation. I loved it, and I'm sure that we are going to find it really useful in the future. And then we will look at other questions in the future. Let's now give the floor to Dr. Cristina Montserrat. Hello to you all.
Cristina Montserrat es titulada, es diplomada en nutrición humana y dietética por la Universidad de Barcelona, máster universitario en nutrición y salud.
She has a degree in dietetics at the University of Barcelona. She has a master's in diet and health at the Open University of Catalonia. And since 1995, she's been part of the nutrition teams in Área Clínica. And in 2010, she created the metabolic adult diseases group at the Clinical Hospital of Barcelona. She has taught extensively. She has a great clinical experience, and she's also a member of several societies and associations, such as the Working Group for Minority Disease. She's also a member of the Spanish Society for Metabolism Genetic Errors of Spain, and she has an amazing amount of work that she's been the author of. You have the floor, Cristina, as soon as you want. Thank you very much. Thanks, Cristina. Thank you very much for these kind words, and thanks for having invited me to be here today and to share these topics about diet therapy in Fabry disease. However, I think I come with bad news because a specific diet for Fabry disease does not exist. So those who are used to treating metabolism errors and specified diets for that, well, this is something we don't have for Fabry. We compiled this. These are the clinical manifestations for these patients and the target organs where these substances are accumulated, ophthalmological changes, also the peripheral nervous system. There are also cardiac involvement, dermatological, cerebrovascular, renal, gastrointestinal involvement as well. And to the right, we see in which decade of the patient's life these symptoms usually appear. And what do we do with these patients? So we basically try to cater for their GI and renal involvement with the diet, especially in boys. We see that these changes happen very early. We see that more manifestations are building up. These then goes on to adult age, and without treatment, this can lead to death. For women, we have a wide range of manifestations. Is much more manifestations are much more heterogeneous in women. But in any phenotype, either the classic or the late onset phenotype, this can lead to heart failure, heart and cerebrovascular accidents, as well as renal failure. All these symptoms, of course, affect quality of life. And what is the relationship with the diet, with a diet a nutritional treatment? What impact do these manifestations have in intake? For instance, a loss of appetite, which then leads to losing weight. If you are not well nourished, probably other organs will be affected. You have chronic fatigue, you're constantly tired, this leads you to depression, and then you don't eat either. And so we embark on this vicious circle where there is apparently no reason. And all these little items do affect people's food intake. I will focus on kidneys and now. We know that kidney disease is probably more prevalent among men. Over 50% of men do have kidney problems, and even if they are following therapy, these renal manifestations become more and more severe over the years. And the diet is basically targeted to keeping preserving good growth in children with the necessary energy and nutrients for these children to develop. It is restricted in terms of sodium intake, but the purpose is basically to avoid the typical manifestations of a patient with chronic kidney disease. That's why we follow the guidelines recommendations. These are the guidelines for which we have chosen to follow the recommendations. And what is the difference between a Fabry patient and a Fabry patient with kidney disease? Here you see the traffic light colors, which show very clearly that in stage 1 or stage 2 kidney disease and albuminuria or proteinuria, we wouldn't do anything. This is basically nothing. However, in patients with Fabry disease, we would start with a dietary treatment, which intends to limit the amount of sodium and the protein amount. Protein control will depend on the stage of kidney disease, and it can be very, very restrictive. And if you are in dialysis, however, it's just the opposite. You need to provide more energy, more proteins, sodium, potassium, and so on. So depending on the stage of their kidney disease, we will have to change the diet, and we need to look at the potential loss of proteins in urine and to give supplementations. And we need to be careful about vitamin D deficiency, which is very common in this kind of patients. Not only Fabry and kidney disease patients, but in the overall population. We need to look at that because that's closely associated to other issues such as cardiovascular diseases and other associated problems. So, as I said, strict control. To the right, we see the guidelines recommendations. And what about sodium? Always, if you have advanced kidney disease, sodium, potassium, and phosphorus, we will pay special attention to hyperphosphatemia and hyperpotassemia. If it's hypopotassemia, if potassium and phosphorus, and if we have peritoneal dialysis, it will depend on the situation. And let me add that we need to look at proteins and sodium, and we might restrict water as well because of edemas. Each person responds differently, therefore we need to give an individual response to this. And the other symptom we often see, it's a mainstream symptom, is GI symptoms. Abdominal pain is probably the most common manifestation for a higher number of patients, and then diarrhea. This chronic or intermittent diarrhea. We also see constipation, sickness, vomiting. This has a great impact in quality of life and often leads to weight loss. It is more often seen in women than in men. And from an earlier age, probably these GI symptoms appear early. And the literature says that Fabry is often underdiagnosed because these symptoms are quite similar to the irritable bowel syndrome, the irritable bowel disease or inflammatory bowel disease. The kind of diet that would be given would be the same for this kind of disease, for IBS. There isn't a specific diet for Fabry disease, but as we have these symptoms, then we will offer the same recommendations. For instance, having regular meals throughout the days and never skipping meals, to have lighter meals, and especially at dinner, and to avoid certain foodstuffs which could be especially stimulating or more could favor more intestinal transit, such as caffeine, alcohol, insoluble fiber, fats, which keep foodstuffs in the stomach, or spicy food, and so on. And what is suggested in the latest literature papers is that it is known that certain carbohydrates are more fermentable, and when they ferment, they could even worsen the symptoms of some of these patients. What would be the most fermentable carbohydrates? And polysaccharides. Here you see in the middle column where you would find them in onions, artichokes. All these foodstuffs should be avoided, depending on the patient's tolerance, at least to be restricted so that they do not ferment and cause distension. Oligosaccharidases, which are found in pulses, as well as in the water you've used to boil the pulses. Disaccharides such as lactose and dairy products, and in some monosaccharides such as fructose, for instance, in certain fruits such as mango, apples, pears, and so on. And there is another group of substances such as polyols with sorbitol, mannitol, lactitol, and so on, which are highly fermentable. And it is recommended to avoid them in your diet. So, for GI symptoms, our recommendation would be to follow the guidelines for inflammatory bowel disease, plus the FODMAP's recommendations. We've seen that, and we have these organic manifestations and this storage of substances, and despite therapy, many of these patients still have symptoms in different ways. So what literature is telling us in recent years is that these patients have an excess oxidative stress. Oxidative stress is probably one of the mechanisms involved in the extension or in the constant duration of this disease despite treatment. GB3 apparently may induce oxidative stress, and literature suggests that inhibiting oxidative stress through nutritional or pharmacological ways would probably be useful to treat cardiovascular diseases or cardiovascular manifestations for Fabry disease, and also kidney remodeling. So what does this mean? So far, we've looked at GI involvement and kidney involvement, and we do a dietary treatment based on the symptoms. However, this is suggesting that maybe we should start acting earlier. Could nutritional or dietary treatment do something for these patients? Instead of treating the symptoms, maybe we could do a little bit of prevention, and here's the word, prevention of the oxidative status that these patients will have. Some of these authors suggest to offer these patients an anti-inflammatory diet. What nutrients are anti-inflammatory? We know that fats, omega-3 and omega-6. Omega-3 are more anti-inflammatory. Omega-6 is more pro-inflammatory. It's not only the kind of fat, but the relationship between them. And it is, well, different authors say 10-1 or 6-1, others say 5-1, but the idea is that there should be a ratio between the two different kinds of omega 3 and 6. Carbohydrates play a very relevant role in inflammation too, especially refined sugars. Why? Because they increase glycemia. Glycemia triggers an insulin response, and then this leads to an accumulation of fat cells, adipocytes, which can create more oxidative and inflammatory status. And we need to be careful with that, therefore, with the kind of carbohydrates. And there are other very relevant substances which play a role in inflammation are polyphenols and also calorie intake. If you restrict calorie intake, it's much better. Instead of having excess caloric intake, probably that is also related to the insulin response. What is the proposal then? The proposal is to try and introduce an anti-inflammatory diet. There isn't such a thing, but the anti-inflammatory diet would compile the advice of the Mediterranean diet and the Okinawan diet. Mediterranean diet is here in the Mediterranean, and Okinawa is a region in southern Japan, and they have lots of things in common, like proteins, dairy products, and so on, and other facts such as having a glass of wine or alcohol. I don't like to talk about this very much because I cannot advise alcohol as a dietitian, but apparently alcohol has a protective factor, a protective role in the Mediterranean diet. And there's also a cultural factor here because both diets, the Mediterranean and Okinawan, share the pleasure of eating, sharing a table, spending time around lunches, and then in the Mediterranean area, the protective factor of taking a nap after lunch and so on. And if we look at the foodstuffs that would be part of this anti-inflammatory diet would be vegetables and fruits, very important because they have high concentrations of polyphenols and a low calorie density. So besides offering vitamins and minerals, they offer fiber. And color variety is essential because in yellow or orange fruits, we find beta carotene or vitamin C, and the red are rich in glycopene. The purple ones in anthocyanins, others in cholates and fiber, and the white ones, such as garlic, they have sulfur compounds. What about protein sources? It is suggested to use more vegetable than animal protein, and if we use animal protein, it should be rather fish than meat. We're also told that we could use animals fed with enriched, omega enriched meals and feed. The same thing goes for eggs. Some eggs are omega-3 enriched. Regarding carbohydrates, not many refined carbohydrates, therefore whole grain is proposed because it offers more fiber and because the absorption of these carbohydrates is much slower. Therefore, it doesn't trigger an insulin peak and it can offer a more long-term response. Regarding fats, we are told that along the protein recommendation, we are suggested to eat more fish. Fish, especially cold water fish, has more omega-3 content, anchovies, salmon, sardines, and so on. This tiny fish have an advantage besides eating the fat and the protein. If we also eat the fish bones, that will also be a fantastic source of calcium. Be careful with saturated and trans fatty acids, and the best fat we can use is olive oil, virgin extra olive oil. And there are also other additional components that these diets include, such as spices and herbs. There are many studies on ginger and turmeric. These have been more widely studied, but what about what we add very little of this, but you could see the impact of larger amounts. So the idea is to use them as often as possible. And another important role is for tea, especially green tea, that has a more anti-inflammatory effect than black tea. Well, and about alcohol, as a dietitian, I don't like to recommend the use of alcohol, but if you have a moderate alcohol consumption, such as happens in the Mediterranean diet, this would be a piece of advice in using the Mediterranean diet. Again, trying to stick to the time I've been allocated, I would like to leave some ideas and some questions in the air. I don't know if there is an answer for them in this forum, but after we've seen all of this, after we've looked at the requirements, we've said that one of the typical GI symptoms they have is diarrhea. It's the second most important GI symptom for them. One of the potential, well, there are three potential causes for this. First, osmotic discharge, because when we eat, we stimulate biliary stimulation, bile stimulation, and if the gut is not working properly, maybe the enterohepatic pathway is not working correctly, and this could lead to osmotic diarrhea. The second cause would be bacterial translocation. This is very widely studied at the moment. The microbiome, the microbiota we have in the gut, this is a second potential cause for diarrhea. And the third one is changes in motility, because that gut has changed from an anatomical point of view. So my questions, we know that many of these patients do suffer this kind of diarrhea. Could this patient benefit from using soluble fiber, which has a low fermentation power, such as planta govata or the beta glucanes that oatmeal contains? A certain amount of some patients have already tested this, and we've seen that they have this has a good result. So maybe this is a potential treatment. Some patients could benefit maybe from taking a probiotic such as lactobacillus and bifidobacteria that would compete with these other bacteria that lead to gut problems such as Clostridium, and which might even make diarrhea more severe. And regarding the use of energy, these patients are constantly tired. They talk about their endless tiredness. I don't know if this is associated with the fact that they cannot use the nutrients because they can't absorb it. Maybe they could benefit from an oligomeric or monomeric diet as a complement to their regular diet to promote this nutrients absorption, because if the energy is not properly used because it's not properly absorbed, then maybe a complement with this kind of formula could work for them. Would it be possible that a mitochondrial disorder is not using energy properly? Therefore, the advice would be having an anti-inflammatory dietary protection should start very early in the diagnosis to avoid the destruction of these cells, because we know that this disease leads to macrophagia and autophagy. So there are, after reviewing the treatment of these patients, many questions come to mind. For instance, a ketogenic diet, nothing has been written on that. And it is also a proposal even for aging. Ketogenic diet, I don't know if you're familiar with it, but the components of the ratio is a very high fat diet, a low carbohydrate, very high fat, very high protein. And if we say that diarrhea, they have diarrhea and fat is not advisable, I don't know if this kind of diet, which is suggested as one of the future therapies, would be advisable for these patients. I don't know, maybe it would on an early age, with early diagnosis, I mean. So I am actually closing my paper with plenty of doubts that have come to my mind when reviewing many of these treatments. Thank you very much for having invited me and for letting me share my concerns with you. I'm leaving the literature that I've reviewed for this. And if you have any questions, my email address is at the start of the presentation and I'll be happy to respond. Thank you very much.
Gracias, doctora Montserrat.
Thank you, Dr. Montserrat. It's been an excellent presentation. We have a lot of questions concerning nutrition. Congratulations to both of you. And now it's the time for questions. Dr. Politei, it is true that with the pandemic, it would have been important to implement home therapy because in the case of these types of diseases, I mean, it would be good to facilitate this option to families and patients. And this is also right for nutrition, depending on what you are born and you live, you have different conditions. Yes, home infusion, I mean, we started that in 2006, that is 15 years ago, we started home infusions. The problems with home infusions are multifactorial. First, and this concerns Fabry, MPS, Gaucher, some drugs, some ERTs in the leaflets from the pharma company do not say that they can be used at home. And so this causes fear in the companies themselves, because at the beginning they didn't want to expose themselves to a conflict in case there was a problem when giving an infusion at home. Since that was not approved in the leaflet, some doctors were afraid of giving infusions at home in case patients had adverse reactions. Infusions at home, it's an off-label indication. So what did we do? We asked for consent, or we signed agreements with patients. So we would all be responsible of home infusions. If the patient wanted an infusion at home, then the company was not liable and the physician was not liable either. I mean, of course, the first infusion would never be made at home. The first infusions would be given in the hospital, and if there were no allergies, we would give infusions at home. And little by little, things change. Unfortunately, protocols are not implemented at home. They are carried out in hospitals. And so some pharmaceutical companies, little by little, said in the leaflets that therapies could be given at home. And then who's going to pay for that? Who's going to pay the infusion nurse, the infusion technician? In some cases, it's the social security. In other cases, the same pharmaceutical company. It's a contribution from the pharmaceutical company to the patient. In other cases, it's the hospital. And here we have different regulations depending on the countries. Finally, COVID helped us. There was no other option. We had to give infusions at home. And fortunately, we are doing that in most of the cases. Great. It's a great and necessary advance. Dr. Montserrat. I mean, it was said that depending on where you live, you have one type of nutrition or other. I mean, maybe if we lived in another country, we would have a better or worse Fabry disease. It depends on where you live, on your hospital, on your healthcare providers. I'm going to talk about the Mediterranean and anti-inflammatory diet, so we can focus ourselves. All countries have foods that have this anti-inflammatory effect. But we have studied the Mediterranean diet. Maybe, we should focus on which are the nutrients that have this anti-inflammatory role. And so we should promote those diets. Because something I looked for this presentation was a map, but I didn't have time to show it. That is, foods, depending on where you live, that you should take to get that effect. But you know what happens? The Mediterranean diet is not just one nutrient, it is one polyphenol, one fat. So the benefit of the Mediterranean diet is the whole diet. And for instance, to choose one ingredient and to say you're going to eat polyphenols or omegas in high doses, this does not have the same effect as the whole diet. I would like to add that I looked for we should look for the foods that have this effect. For instance, DHA. How many of us don't get enough DHA in our daily intake? How many of us do not get enough fruit and vegetables? The food patterns are different in different countries, but we should look for nutrients that have an anti-inflammatory effect. And from time to time, to toast is a good thing. Yes, this is what some people say, but be careful with high graduation alcohols. I have a question for Cristina, because one of the problems we have when managing Fabry disease is abdominal pain, diarrhea. We have animal models. We know about the autonomous nervous damage. And we give patients drug treatment for irritable bowel syndrome, as you described it, but we know that diarrhea is caused by dysmotility and bacterial overgrowth. And some important Spanish studies mention the change of the bowel microbiota towards a microbiota with less hydroxybutyrates. So we always say we have to give probiotics. And now my question, and I don't know anything about nutrition like most of the physicians, what should I give the patient? Shall I tell them to buy the yogurt with probiotics that has been advertised on TV, or do I have to be more specific? Okay, if we want shock therapy, give pharmacological treatment from the chemist, and different things. In the chemist, you may have, for instance, just one product with one strain. It's better to have products with more strains, not only lactobacilli, for instance, because we have a wide range of these bacteria, and not only bacteria. There's a whole world. And so the ones, we should have several in a shock therapy. We have pills, we have different presentations, and the doses are very different depending on the presentations. I would start with a high dose. For instance, you have some in little sachets, and you can give one dose per day. And you get a whole series of bacteria in one product. For instance, iron, vitamin D, calcium. Once it's been restored, it's important to keep the levels. And how can you do that? With yogurt, with soluble fiber, with foods that help those bacteria to stay. But this would be a second stage. Thank you. This is very interesting. And I have a question for Dr. Politei. Yes. Yes, concerning vaccines, don't they interfere with pharmacological treatment? They should not. Like any vaccine, if you want to generate an inflammatory response, they don't interfere. I mean, I'm going to give an enzyme that's going to circulate in the patient for 36 hours. At 36 hours, the enzyme has been internalized by the cells and lysosomes. So there's not an immunological attack that has not been shown. Another situation therapies in autoimmune diseases. If I have been given a immunolation drug because I've been transplanted, this is different. But fortunately, there's no direct relationship. Sometimes I get questions from patients about contraindications of the vaccine because they think they may have side effects with today's therapies or future therapies, because this is probably going to change in the future. Cristina, we are also considering this with the normal flu vaccination. Patients get flu shots every year and nothing happens. And so we have to tell the patients, get the vaccine you have in your country. Dr. Politei, it is clear that to discontinue enzyme replacement therapy is not good. We see lysosomal storage. And if they discontinue treatment, the patient is going to lose all the benefit they have achieved. So it's better to get the vaccination without discontinuing treatment. And you already said it. I mean, at the beginning, we had many questions, and in the associations, they would tell us that they didn't want to the hospital because they thought they could get infected. And this is why they didn't get treatment. And they have lost quality of life. They have worsened and they have wasted time that they had won. That's right. And and finally, concerning nutrition, we still have many things to learn, but there's something we need to know. Shall we do a personalized study for each patient concerning their nutritional status? We all have intolerances, or we get bloated after eating certain foods. So maybe together with the medical team, we should have a nutritional study, for instance, in Fabry disease or other diseases. Yes, that is true. And this is what I said during my presentation concerning upon diagnosis, we need nutritional follow-up. Sometimes we do that very early, every certain months or weeks. But I mean, we should anticipate to problems. We should give materials to the patients to tell them, if you have this problem, do this. We should anticipate to what may happen. And what I said, a low intake. We should give them tools to increase the intake. You have pain, you have a drug which works. What are you going to do when you don't have pain? Or when you don't have pain, then you may eat this or that, or don't eat these things because you will get satiated, but you don't get nutritional food. So as soon as we can give nutritional therapy, the better. Okay, so if there are any more questions, we'll try to answer them at another time. And now the next presentation.
Bueno, pues muy interesante estas dos ponencias. Vamos a otras dos que son.
These two presentations have been really interesting, and now we're going to move on to two more topics which are very relevant in this kind of diseases. Now we will start talking about, well, how to stand up to Fabry, how to cope with Fabry. It's Professor Eduardo Brignani. He always collaborates with us. He is a teacher in psychology, and he's been in Spain since 1992. He's a psychologist, psychotherapist, and coach, and he's been working with patients from many different institutions. He works with rare diseases in Catalonia. He also works with the sector of intellectual disability. He's worked with the Rett Syndrome Society, Cornelia de Lange Society, the HPN Association, Fragile X, or MPS Spain, and so on. So he really is working with many different institutions. He also offers courses, and he's worked in, he's one of the founders of the working group on psychology and disability at the Psychologists Association of Catalonia, and he also works with minority diseases in Catalonia, and he really does a very great job. He is a very prestigious person and very well known in this world, and it's a pleasure for me to introduce him. So, Eduardo, the floor is yours.
Muy bien, buenas tardes.
Good afternoon. It's a great pleasure. Thank you very much, Jordi. I would also like to thank the organizers and Dr. Pinto for allowing me to share some thoughts with you. Just a few thoughts that I would like to share with you. This is an invitation for you to do the thought process yourself, because this is the first question that I would like to throw at you. Why should we stand up to Fabry? When Jordi called me and asked me, what title should we give to this idea, to this section where a psychologist would be there, Jordi actually suggested this idea. In Spanish, we call it plantarle cara. So standing up to Fabry, very often our parents or teachers, when faced with a difficult situation when we were children, probably told us we should stand up to whatever difficult situation we were facing. The idea is to face up to adversity. And this is what I'm going to ask you to do. And we will do that by showing a few things. This is the question. What needs to happen? What needs to happen, and is in your hands to improve your life and the way you live with Fabry? Because if your life improves, I'm sure you will be able to cope better with this disease. It's a disease that nobody wanted, but it is there and it lives with you. And well, it dawned on you and it fell on you as a piece of as some lightning, and then this became a big puzzle, a big jigsaw, and you need to keep the pieces together. So what should happen in your life, something you can do with it, so that life improves? Because the challenge is this: how can you fit Fabry in your life and not the other way around, so that you can carry your own life, so that your life is not carried by Fabry itself? Very often we hear about a concept when talking about functional disabilities. It's called empowerment. This concept of empowerment is widely used, and it has to do with positive psychology. The School of Positive Psychology emphasizes on how to work with adversity, and this builds on another concept from physics: resilience. Last year, politicians in Spain, and I'm sure that in many other countries too, because it's not something strange, politicians started talking about resilience budgets. Therefore, that would be a budget for the Spanish state aimed at standing up to COVID and the COVID problems, facing up to COVID. And that's why we are going to talk about what facing up to Fabry could actually mean for us. Look at this cartoon. I'm going to use, the author is not there, but it's an Argentinian lady. Look at this situation. Oh, my nightshirt weighs half a ton. Well, this is the dilemma, right? What about accepting our situation? The first thing to face up to Fabry is accepting it. Not finding excuses, as this lady who's trying to find an excuse in the weight of her nightshirt. Same thing for men. Maitena, who is the author, is placing men and women in the same situation. I always say that the scale is not working and we should change the batteries because I don't like the number I see there. So let's talk about acceptance. If there's no acceptance, there is moral pain. And you know that perfectly well, because the day you received your diagnosis, and I've had the chance to accompany several people on that process, on that journey of accepting their situation, which overnight changes on the day which changes overnight on when they receive their diagnosis. So there is moral pain when we do not accept reality. The opposite to acceptance is not well, the opposite is denial. And acceptance is an essential process. If we do not accept, then there is a moral pain, this suffering, because there's this big struggle between reality and our imagination. Look at this sentence, at this quote by Viktor Frankl. If changing a situation that causes pain is not in your hands, you can always choose your attitude to face that pain so that you don't fall in suffering. Viktor Frankl is a man, he's a professional, he's a psychiatrist who did a doctorate in concentration camps. By the time he went to the concentration camps, he was already a psychiatrist, but that's where he coined a whole approach, a whole psychological approach based on framing, making sense of what happens to you. So pain is always there. Pain will exist in everybody's life. We have different kinds of pain. Dr. Montserrat referred to pain. She talked about abdominal pain and how to approach it from a dietary therapy point of view. But what happens with moral pain, with moral suffering, psychological suffering? Why is it my daughter affected by this? Why do I have this and then I pass it on to my daughter? This adds to your pain, and that pain is even bigger than suffering Fabry disease yourself. And the only thing you can do is to adjust to the way you face up to pain. And that is something that Frankl teaches us from his Academy of Life, the Academy of Life he went through in the concentration camps. He talks about making sense out of life so that you can overcome suffering and so that you can overcome pain, and that pain does not become suffering, because when you don't have a choice, the only choice is you. And that is a quote by a mother from India, Sethi, She had a son with an intellectual disability, and there was no school for him. All doors closed on her. And in her loneliness and in her frustration, she realized that when you don't have a choice, the only choice is you, because you did not choose Fabry. Genetics did its own work. It's the workings of genetic. And who's responsible for that? It's only nature. Why me and not why somebody else? Well, because that's nature. So when you can't give up on what you have, do not give up on the fact that you are the axis of life. Look at this cartoon. This is a cartoonist from La Vanguardia, Kino. Look at this reality. This idea becomes a whirlpool which surrounds the person who's sleeping. This eddy embraces and absorbs the person, because facing up to Fabry means suppressing the sterile concerns and rumination. Look at what concern is. Concern, a worry, is a catastrophic chain of thoughts always placed in the future, but there are some positive worries. You have a problem and you surround that problem with questions in the quest of in the purpose of finding a solution. But there's also a sterile kind of concern which does not lead to any change in your reality, but rather overwhelms you, stops you from sleeping, encapsulates you, and you become shy and hostile because people ask you what is happening to you, and then you say nothing, and then you're because you don't want to worry anybody else around you, and then you worry people even longer. Well, that's a sterile kind of concern that brings nothing good, and that's something we need to avoid. And rumination is a negative chain of thoughts that have to do with the past, not with the future, but with the past. Why didn't we do this? Why didn't I do that? So this pointless rumination is something that goes around and round in circles. Where does it bring? Where does it take you? It takes you nowhere, because rumination isolates you. Rumination turns you into someone who is locked up in his own concerns. These are two cognitive processes which have an adaptive function. It is normal that you start by being worried or concerned or ruminate. But if this becomes chronic, it prevents you from leading a normal life, and it isolates you from the rest of people. When these things are dysfunctional, when they don't lead to any changes in reality, when they are impossible to control, they are repetitive, and they grasp you, and you become like that cartoon we saw earlier, and you are caught up in that eddy, then it shatters your life. Let me tell you something else, and it has to do with how to manage emotions. Look at this gentleman. The wife asks, "What do you feel? You never talk about your emotions." And then the gentleman thought about using these emojis to manage his own emotions, because managing emotions is a way of facing up to Fabry. Another way is humor, as we can see in this cartoon. And here it says, "I asked for a boat, not for an iron." This boat and iron sound very similar in Spanish. It's a pun we cannot translate. But well, life is better with good humor. Life is better because good humor helps you live better in that island Fabry landed you in. Humor is an antidote against depression. Humor is an antidote against negative rumination and concerns. Humor is also a way of learning to laugh about yourself and to question yourself, to take things more lightly. Because if things have a solution, why are you so worried? And if they don't have a solution, why are you so worried? Look at this other cartoon by Tute, an Argentinian cartoonist. He is a member of a family of cartoonists. Actually, his father was also quite a character, very well known in Argentina. Argentina, where both Juan Politei and myself come from. And he surely knows about Clemente, Tute's father. Do you love me? Yes. And did you buy the lettuce? And he says, all the way to heaven, my love. And the children say, well, they don't even listen to each other because standing up to something means working on communication. And it is essential because many of the problems we see when Fabry comes into your family life is that the person with Fabry usually shuts up. They become emotionally locked up, encapsulated. They are isolated from the rest. And the family members want to know, they are concerned. So communicating is essential. You need to be able to communicate from your emotions, and you need to be assertive as well. You need to be able to say how you feel. I am like this. At this point in time, I feel such and such a thing or such and such pain. I need a bit of isolation, and I'm sure that everybody else will understand you. So, communication, if there's a malaise or if you're not feeling well, very often communication becomes something much more aggressive. You move on to wrath, and very often this wrath and madness and so on, and this might lead to rupture. You need to be lighter, to take things more lightly, because facing up to this mean that you need to remove all the weights. Maybe as you have Fabry, you cannot go and hike in the mountains. Well, then find other situations that make you feel good with yourself and with others. Oxytocin is the solution. It's not cortisol that is the solution. It's like this neurologist. The psychologist says, well, this doesn't look good, Remigio. I think this keeps on growing and it will still damage how everything works, because love needs to be generated, managed, and you need to allow others to love you. You need to allow others to protect you and look after you. I know this is a little bit outdated, but hugs don't seem to be fashionable at the moment, but let's hope that we can get many, many, many hugs in the very near future. So far, we've been hugging ourselves with our gaze. Look at this. How do you do so that this wind doesn't undo your hairstyle? And she says, I think about something else. And that's what you need to do, because otherwise you're going round and round in circles, in your concerns without having a positive view about what is happening to you, means that everything will fly away in the wind of your negative thoughts. Look at this picture. I couldn't find a picture I could show of someone who was climbing up on skis with somebody else. But what do I want to show with this image? You don't walk alone. You need to find a network of support, and you need to use it, because as Boris Cyrulnik says, he is another author of the New Psychology, and he works on empowerment and empathy. what we were saying about resilience. And Boris Cyrulnik has a very, very nice book, The Ugly Duckling. When he was young, he also suffered the Nazi persecution because he was a Jew, and his mother told him, forget about the fact that you're a Jew. And he forgot about that until he became an adult. But all his childhood and adolescence, he was running away from, he was flying away from the oppression, and he was finally raised in a Christian family, and he forgot about the fact that he was Jew just to save his life. When he studied psychology, he tried to explore and conceptualize what he had experienced. And he says, a wound is not a fate. Of course, we are talking to people who are suffering a chronic condition, a Fabry chronic condition, and wounds break up, open, and then they close back again. So you need to keep on going. You need to try and find your path to live with Fabry. And these two children, this is a very tender and a very sweet image. One climbs up on the other to try and be at the same height as her. Why? Because we need to look after our inner child. What this child is saying is, would you like to go out with me? Sometimes if we forget about our inner child, we forget about the possibility of awe and wonder. So let me invite you to watch a video now so that we can think about how we should not lose our inner child. In this video clip we're going to see in a second, you will see a father and his child. But let's look at this video clip from a personal point of view. One part of me is a father. This comes from transactional analysis, another psychological school, a version of the father, which is, well, the rule, what makes us responsible, what makes us compliant. And then we also have the part of the child, something we often lost along the way. But being a child is essential. These children who are so happy when they find out something new, who can share things, and who make sense of the things that happen to them. Let's have a look at the video clip now.
bien. Recuerden, porque
Oh, very well. Remember, very quickly, this video clip that we could stop now so that we can show again the PowerPoint presentation. There you are. This video clip is very easy to look at it from a parental point of view, the father and the child. But no, that's it. There's another child inside you who can lose color. And there's a father who's you, your own self, who can lose his color unless you face up to Fabry, because that's the big question that I would like to leave with all of you. Where's your square? Where is that square where you can play your own melodies and regain color? The color of facing up to Fabry, facing up to the fact that you live with the reality you did not choose, but is there for you, and you deserve to manage the situation of these problems that you are facing in order to have a better well-being for yourself and for the people you live with. I would like to give you this refreshing embrace, at least for those who are in the Northern Hemisphere. And we intend with this to mean that we will soon be able to hug ourselves. So I'm sending you a virtual embrace, a virtual hug full of oxytocin. Thank you very much. Thank you very much for your patience. I know that I overrun my time a little bit. Natalia, my apologies, but thank you very much to you all. See you.
Gracias, Eduardo.
Thank you, Eduardo. It has been a great presentation and very, very comforting. And now we're going to move to Natalia Rubio. Natalia is going to give us an extraordinary presentation. She's a psychologist, sexologist, pedagogist. She's an expert in sexual education. She gives sexological counseling. She's an expert on gender approach concerning equality, and she's the president of Sexuality and Disability Spanish Association. She has a master's in sexology, and she's an official teacher in the master in sexology, and she collaborates with different associations, with the Autism Spanish Association, the Rare Diseases Spanish Association, ALS Association, and she's the director of Peoples and Life Projects. She has published many papers, best practices. She's worked on sexuality a lot. So without further ado, Natalia, you have the floor. Thank you very much, Jordi, for your kind introduction. Good afternoon. It is a pleasure to be able to share a few minutes with you. We're going to talk about a different topic, sexuality. So, in order to start, we're going to do something. I'm going to invite you to think for a few seconds, if we're going to talk about sexuality, what do we think about when we hear the word sexuality? Let's imagine we're walking in the street, and we walk past a group of people and we hear the word sexuality. And what images, what situations, what memories, what sexuality-related words we think of? Or imagine you're watching TV, you're zapping, and we see one of these reality shows and someone says sexuality, what do we think about? What images, situations, memories, sexuality-related words we think about? Imagine that all of a sudden we switch on the microphones and we all say loud what we have thought about. But don't worry, we're not going to do that. Don't go away. But I don't know if you agree with me. If we had to say everything we thought about, maybe many of us would do a kind of exercise. We would like filter a few words. Do I have to say this loud? Wait, this word, I'm not going to mention this loud. But no, I'm not going to mention this word. That other word, I don't know whether it is related with sexuality or not. I'm going to say this one because it's not that strong. Would you agree with me? It's quite funny because sexuality is something that we talk about in our daily life. But do you think that everyone here do have the same idea about sexuality? Maybe we all have a different idea concerning sexuality. As you can imagine, every person has a different idea of sexuality. Today, I mean, we have created an idea depending on how big, on how small this idea is. We will live that sexuality with more and less anxiety. If we have children with Fabry disease, depending on how big or small is our idea of sexuality, we'll see if sexuality is related with our children life project. Sometimes we don't want to think about sexuality because it may complicate our life. So what do we based on our idea about sexuality? It will depend on our sexual education, whether sexuality was taught at school or not. And that idea of sexuality will also depend on the fact whether we could talk about it with our parents. Our parents maybe would change the TV channel when there were sexual images on TV. And, you know, they were saying something by doing this. And that idea of sexuality will depend on whether we've been able to talk about those topics with our friends. Sometimes we may not talk about that. Well, when I invite people to say what they thought about concerning sexuality, people, males and females, boys and girls, say, for instance, skill, taste, caresses, trust, men, adolescence, orgasm. So one word leads to many ideas, but we're interested in your ideas because the idea of sexuality belongs to you. First idea, it's not the same if you think about certain images and memories. I mean, we could have thought about words related with genitalia. Maybe we have thought about the penis, the scrotum, the labia, or the perigenital area. Or maybe we have thought about bigger things. Maybe we have thought about the hands, about the neck, about the back, about the glutei, the feet, the hands, the mouth, or the skin. because we're talking about different things. Usually, there's a common idea in our society, which is a misconception, and many people say that sexual education means encouraging people or telling people how to use their genitalia. This is a misconception. I mean, in sexual education, we have a wider goal, a most important goal. Our goal won't be to tell people how to use their genitalia, but it will be to coach people so they can manage their bodies. And this is related with words such as body, modesty, sense, but at a social level, there's some men and women, who are fans of the genitalia. They think that genitalia are the most important thing to enjoy sexuality. Some people think that to have sexual pleasure, genitalia are the most important thing. And I'm going to tell you something. What would happen to these people, these fans of the genitalia, these men and women who think that sexual pleasure depends on the genitalia? What would happen to them if one day the genitalia would not work as they think they should work? What would happen to them? As you can imagine, they would end up frustrated, I mean, without sexuality for the rest of their lives. You are here in this Fabry conference, and I have to tell you a sexological secret. All men and women who are here, and others who are not here also, all of you who are here, along our lives, our genitalia will sometimes frustrate us. Maybe you will think nothing will happen to my genitalia, but this is not true. This is non-negotiable. It may happen lots of times along our life. But why our genitalia are not going to work sometimes as we would like? Maybe because of age. Our body and our genitalia within our body are not going to work the same when we are 15, 20, 37, 47, 52, 69, or 93 years of age. There are certain muscle groups that are linked to certain responses, but this is not the only factor. Age is one factor, but there are other factors. Sometimes we live situations in our life which are very stressful, stress, anxiety, anguish, COVID pandemic, I can't get out of house, vaccines, now I'm not working my regular shift. We're stressed, anguished, and our body sends us signals, and our genitalia changed all of a sudden. You know, there's no erection anymore. And for women with vaginas and vulvas, I mean, we are stressed. And what happens with lubrication? So stress, anxiety, anguish, this will have an impact on our body and genitalia. But there are other reasons why our genitalia are not going to work as we would like to. For instance, we may have an emotional crisis. Maybe a family member has died and we're a bit depressed. We need a mental health medication, and all this has an impact on the functioning of our genitalia. So psychopharmacology may cause also an alteration in the function of our genitalia, both in men and women. But there are many other reasons why our genitalia may not work as we would like to. Sometimes we go to a health center, for instance, for high cholesterol, high blood pressure, diabetes. Sometimes in this common chronic disease, for these common chronic diseases, we get prescribed certain drugs, and those drugs for hypertension, high blood cholesterol, diabetes, have an impact also on the function of our genitalia. But there are other reasons. For instance, some disabilities, such as medullary injury, this may have an impact on our genitalia too. But there are many more reasons why our genitalia won't work as we would like to. So if we combine or if we rely only on our genitalia for sexuality, there will be many times during our life that we'll have a hard time. Sometimes they want to convince us that there are many people, they tell us that genitalia are very important. They are everything in sexuality. But what I'm asking you is to change the way of seeing sexuality. Sexuality is all over the body. Genitalia, are important, but they are not everything concerning sexuality. Did you get that? But let's go back to words, to ideas, to images when we were thinking about sexuality. It's not the same to think about words related with certain attitudes, such as intercourse. Intercourse are penetrations. When you thought about sexuality, did you think about bigger things? Did you think, for instance, about kisses, caresses, walking hand in hand, sleep, hugging your partner, sharing secrets, licking the other? All this range of possibilities. Here you have a slide, but I could have shown you 17 slides. There's a second idea at the social level, and it's a misconception again, and it's that many people think that sexual education aims at encouraging people to have sexual relationships and sexual intercourse. This is a misconception, I insist. We're talking about bigger things. We're talking about more important things. When we talk about coaching sexuality, we want to coach people so they can establish interpersonal relationships. And a question here. Does everybody have to like sexual intercourse? No, I'm hearing you. Of course, there are many people who do not find pleasure with sexual intercourse. They say, I'm fed up of sexual intercourse. I'm sure you've heard people have told you that they don't enjoy sexual intercourse. Or maybe not. When I teach sexuality to adolescents or adults, but especially with adolescents, and when I ask them, when you think about sexuality, what do you think first? About sexual intercourse or about kisses, caresses, walking hand in hand, hugging your partner when sleeping? And adolescents and young people look at me and tell me kisses, caresses, licking each other. Isn't this foreplay? Well, as you know, this now in Spanish is called entre meses. This is foreplay. And now Foreplay in Spanish is called entre meses. I didn't know that word in Spanish, and I asked them, I mean, you mean that sexuality could be like a kind of entree in a restaurant, which is what entre meses means in Spanish. And you know, I started to think about certain dishes, and I could say sexual intercourse is my favorite course. Oh, macaroni cheese are my favorite dish. I don't know what you will think. 3, 4, 5, 6, 15, 20 years eating macaroni cheese. I mean, it will be too much sooner or later. So, as you know, sooner or later, it will be too much. If you don't see that, if you don't think that this will happen, I mean, maybe that could be the case in some young people, but I have to remind you of something. Some days we feel like eating macaroni cheese, macaroni cheese, macaroni cheese, or we want to have sexual intercourse, sexual intercourse, sexual intercourse. But remember that not always, we're not always going to have the genitalia al dente. I prefer the Mediterranean diet, vegetables, paella. Well, maybe you will value macaroni cheese one day, but if you have to eat macaroni cheese every day, I mean, it will be too much. But anyway, some people eat them one day after the other, nonstop. I mean, we could talk about this for a long time. I mean, when people talk about sexuality, do they tell the truth or do they tell what people want to hear? So that was all I wanted to say about this. And now let's think about those words, about those images, those memories you've thought about. Third idea. I mean, have we thought about words related with orgasm or words related with pleasure? What would be the big thing here, orgasm or pleasure? What do you think? Orgasm or pleasure? Oh, pleasure is the big thing. To see the difference between orgasm and pleasure, I like to compare it with something. I'm going to tell you. The difference between orgasm and pleasure is how we travel the enjoyment of sexuality. Today is Friday. We could travel through the enjoyment of sexuality. So I invite you to travel through the enjoyment of sexuality, because depending on how you travel, you will enjoy more or less that trip. So let's travel through the enjoyment of sexuality by train. We're going to leave from Barcelona and we have two possible destinations. We're going to stay in Spain. We're going to go from Barcelona, for instance, to Cádiz, to the beaches in the south of Spain, or we could go to Paris. Which of these two destinations would you prefer? Jordi, where are we going to? Do we go down to Cádiz or do we go out to Paris? Up to Paris. Okay, we're going to go to Paris. We're going to do that trip through the enjoyment of sexuality. We leave from Barcelona and we're going to go to Paris through the enjoyment of sexuality. Think how each of you do that trip through the enjoyment of sexuality. First option, some people, some men and women, during that trip will get on the train next to the window And when the train starts, or even before, they get close to the window and they stay like this. When are we going to get there? When are we going to get there? I'm getting bored. This is very boring. I want to reach the orgasm. I want to reach the orgasm. This is very boring. I want to let myself go. Some people travel like this. However, there's a second way of doing this trip along sexuality, and some people get in the train, they sit next to the window, and when the train starts, they start looking through the window, and they do that. Look at that. Look at these trees. Their color, they're very beautiful. Look at those green fields and those two mountains. There's a waterfall and there's two cows. So they enjoy the landscape. Do you understand the difference? Maybe it would be worth to consider the trip through the enjoyment of sexuality this way, like, a promenade, especially when the weather's nice. Are we going to are we going to go for a walk? Which is the goal of going out for a walk? Is it the destination? Most of the times it is not. The goal is to enjoy the company, the conversation, the smells, the views, and maybe it would be worth to enjoy this way. Because if we have said that sexuality is related with the whole body, which is the territory to travel, well, some people in their life, they say, I'm going to travel around my body, my sexuality. This week, I'm going to enjoy Galicia. And next week, I'm going to go down to La Manga del Mar Menor. And the other week, I'll go to Extremadura. And the other one, I'm going to go to Cádiz. And some people will always go to the same place, to Benidorm, for instance. That is genitalia, genitalia, genitalia. They won't change. So, you know what I mean. What does this mean? Well, maybe we are missing things. There's many places to travel, to enjoy, and maybe we should consider that trip through the enjoyment of sexuality that way, getting to know all places. If I ask you, when can we start enjoying sexuality? It depends on the model you choose. For instance, people who choose that narrow model of sexuality, genitalia, intercourse, orgasm, they think we'll be able to enjoy it at 18 years of age onwards. In a high school, someone told me earlier it was 18, but now the law has changed and we can already enjoy sexuality at 16. But if sexuality is related with the whole body, when do we have a body? When we are born. And that body is going to accompany us all our life. So we'll be able to enjoy sexuality from the moment we are born and during all our life. What are we going to do to enjoy that body? It will be different when we're 5 years, when we of age, when we're 15, 27, 49, 57, or 93, because tastes and motivations will change with age. And what we do to enjoy our body by ourselves or with someone will change over the years. Think about what you're doing now to enjoy your body. Is it the same what you did 10 years ago? Probably not. And maybe what you're doing now, it's very different from what you will do in 10 years' time. Why? Because tastes and motivations will change. I'm going to finish here because of time, and we can talk during the Q&A. Jordi?
Muy bien, muchas gracias, Natalia. La verdad que tienes...
Thank you very much, Natalia. What a drive, what a drive, what a thrust you have. Your passion is amazing. These have been excellent presentations, and I think that you have really encouraged people to stand up to Fabry disease, both of you, not only Natalia, but Eduardo as well. We need to be aware of the fact that life needs to be enjoyed in all ways, and that macaroni and cheese are wonderful when you eat them from time to time. This is my favorite dish. So from time to time, macaroni and cheese, great. Okay. To be frank, I was looking at the questions here. And let's see what we have.
No hay. Nadie se atreve.
Nobody dares. No one dares. You have overwhelmed our audience. Jordi, I have a question. Sent by Dr. Guillem Pinto. And this is a question that says, it seems that in Fabry disease, it is very common to have depressive traits. What would be your indication if you do group therapy to try and solve this? Thank you very much, Dr. Pinto, for this, for allowing me to deal with this topic. First of all, group therapy is one type, but we can also have individual therapy depending on the possibilities and depending on the kind of services that you can offer. Well, beyond the etiology, the cause, and we could discuss about that, about the reasons for depression. From a psychodynamic approach, psychologists say that depression is just an aggression against oneself. So an aggression which should be expressed, but turns against yourself. And I think that this is very relevant for Fabry. In my clinical experience with people who have Fabry and who have these depressive traits, or sometimes have a stage of marked and severe depression. And let me say that the medical approach with pharmacological treatment, psychiatric treatment, is necessary in certain cases. However, along those lines, that the idea that depression is an aggression against yourself, as we said in one of the slides, which is very, very summarized, we were talking about the role of emotions, the negative emotions, as they are called, misnamed as negative emotions, such as frustration or wrath or disgust. Natalia was telling us about the emotional variety of interactions within a couple, or the interaction in a certain sexual situation, the component of emotions. And this miscalled negative emotions, such as wrath or frustration, and that have to do with the situation of having a disease such as Fabry that does away with all your plans, with your force, with your routines, because you have to go to the doctor and see if you have a heart checkup, or this idea that you need to be on constant alert. Well, unless there is a proper management of these negative emotions, it's very easy to slip down to a depression. So the approach And let me defend my profession. That's why MPS Spain and Fabry Spain has seen this for many years, and they offer their associates psychological support service. And they also offer them a consultancy service to deal with issues that have to do with sexuality, as Natalia just told us. So thank you very much, Dr. Pinto. I tried to be clear in responding this question. I don't know if I managed to. Natalia, what do you think about this? Would you say patients
o muchas veces les pasa que no se encuentran a la altura?
I guess patients always find that they are not up to it. Will I be up to whatever? Psychologically, very often. Will I be able to do such and such a thing? Sometimes patients find it really hard to travel and to say, I'm going to Paris. And they say, okay, I prefer to stay in my own town because I don't dare. Well, it's obvious that every person is different. Sexuality can be enjoyed in many, many, many different ways. So diversity is one of the features of sexuality. And we often are fooled by the idea that everyone needs to like the same things, that everyone needs to like macaroni and cheese, that is a must. So let's create different scenarios to remove a little bit of anguish and distress from lots of people, because the only purpose is satisfaction, is enjoyment. And your enjoyment is achieved thanks to doing things that you like doing. And satisfaction is also achieved by not doing things we don't want to do. So let's not be fooled and be influenced by what people think that everyone needs to do. For instance, the fact that sexuality needs to be experienced in a couple. Maybe I'm not on par. Well, maybe our partner is not asking us to have a coitus, sexual intercourse, or maybe they would enjoy better with, I don't know, having a bath or having a massage or doing many other different things. So we need to grow this little garden and to look after the garden of sexuality and to extend all of the panoply of eroticism, because it is true, art and Italia will fail us. And that is something that happened with the persons who live with people with Fabry disease, but it happens to all of us throughout our lives. Therefore, it is essential to say, well, maybe today is a good day, or maybe today I want to have macaroni and cheese, but my pasta is undercooked or it's overcooked. And so let's do something else. If we think that the only thing we can do to enjoy sexuality is having sexual intercourse, if we only think that, well, then our approach will be very different to having all these other armamentarium, other possibilities of enjoyment. And I can enjoy myself on my own or in company, so with others. So I think that opening up our horizons is very useful for all of us. Very often we punish ourselves with things that we don't even share with our partners. And this is something important too. And then sexuality is very, very relevant. And there are professionals who can help us solve problems and situations that do happen, because very often we have trouble, we don't want to share it. And if we don't want to share it, then we don't ask for help, things do not improve. Yes, it is true that this consultancy, this guidance is very helpful, very, very important. It is important to walk along people who can help us. Along the same things, Natalia's idea, which is based in cuisine, and I love it. Well, this is a communication issue. It is very difficult for a couple to communicate in bed if they are not able to communicate over a coffee or walking around or sharing a situation, because it is true that sometimes things can be solved in bed, but very often it's just the opposite. That's where conflicts come to the surface. It's not the cause, but the result. And what Natalia is inviting us to do, changing our look on things, changing the way we look at this, because we're talking about satisfaction, different levels of satisfaction with different levels of commitment too, and different elements that make up that satisfaction. I love it. I just love it. The only thing I don't like about this is macaroni. Macaroni and cheese, I don't really like it. Imagine my name, Brignani, Italian name. Well, there are many different types of pasta, not only macaroni, and lots of different types of dressings for the pasta. Guillem is asking me, Natalia, can we teach people to enjoy sexuality? Sorry, it was sent in the chat. Okay. Can we teach people to enjoy sexuality depending on their age or physical features? Of course, offering support to sexuality is something we can do at all ages. Okay, if we're talking about bodies, eroticism, and pleasure, because it's worthwhile to have a wider horizon. If we said that over time, in our lifetime, we will all have trouble to call to fit in the narrow model of sexuality, which I call the model of anguish, of anxiety, we will all have trouble someday in fitting in this narrow view. So let's find another model that allows for people to fit in widely. In this wide-ranging model of sexuality, we can fit everyone, regardless of our age, regardless of whether we have a partner or not, regardless of whether we want to have a partner or not, regardless of our sexual identities and our leanings in desire. Everyone fits in, and from a very horizontal perspective, all on an equal footing. When we talk about sexual education, the important thing is to learn to know it ourselves, to accept ourselves, and to enjoy in a satisfactory way without getting into trouble. That's why sexual education can start very, very early and can be with us along our lives. We will all do well if we learn about ourselves, if we are able to adapt to changing circumstances in life and to be able to enjoy either on our own or in company. And when we get into trouble, sometimes motor difficulties, we do have options. The fact that we have certain motor and functional constraints, that do not mean that we should give up and say, okay, now I can't enjoy my body. Let me allow the organization to put the slides back. I will show you some support products. Thank you very much. You're so quick. Thank you. It's wonderful to work in that way. For persons who have motor or functional constraints, now I'm controlling this. Okay, wonderful. For many, many years, I started thinking about this because we're all entitled to enjoy our bodies autonomously. So I thought about designing a range of products, and not all demands will be focused on the genitalia, but around the body, along the body, full body. But what happens if we have motor or functional constraints because we have spasticity, because we have rigidity? Well, in the last few years, we have moved forward in adapting lots of different things. We're now offering what we call support products. They were called technical aids. Now we call them support products. Well, these are personal products that help us enjoy our bodies on our own or with our partners without these functional and motor constraints preventing us from enjoying this. And among these, we have gloves, which simulate movement with vibration, and we can use that with ourselves or with somebody else. I'll show you. What can this be? This looks like a catalog for Christmas products. Well, that is not. These are stimulators, dildos, vibrators, and they are devised, these ones, they are focused for people who have penises and testicles with their adaptations for a wheelchair or for a bed, and they can be handled through an app or through the systems you have in the wheelchair. So there's a huge variety of things we can do and we can use to keep on enjoying our bodies. And if we prefer to use our genitalia, well, regardless of the kind of genitalia that we have, whether it's a vagina or a penis, well, there's plenty to choose from, depending on your profile and your preferences. And in Spain, we are currently experiencing a time, for instance, in CERSO, which is the reference center called CAPAD. In the upcoming catalogs, they will add support products for the enjoyment of sexuality as well as part of the catalog. So adding sexuality at the same level with the same kind of consideration or relevance as other areas of a person's daily living activities. And I wanted to tell you about this because I want you to know that these things exist. Sometimes they might be necessary and we can buy them. And I was that goes along the lines of the question that was sent. So these are the references. I can give you a hint of where you can buy them because this could be useful at some point in time. Thank you.
Muy bien, muy bien.
Thank you. This is amazing. And you answered the question. There are plenty of tools nowadays. We can use plenty of tools, both psychological and psychological aids, sexuality aids, all kinds of aids. And this is, of course, very necessary to have tools which improve people's quality of life overall. Okay, I think it's about time to call it a day. I would like to thank you all.
Y ya hasta la próxima.
And hope to see you next time. Thank you very much. Enjoy. It's been a pleasure. Thank you very much. Thank you all. A big hug to you all. Thank you. Let's stay in touch. Okay, see you soon. Thank you. Bye-bye. Ciao, ciao. Ciao.